Guys did a learning activity on this with Professor Romo. So this is a little bit of repetition in part because you already know it, right? So what's tuberculosis? The suffix osis means a condition, so it's a condition of tubercles. So it's a tubercle, right? Well, I mean, it's a condition of tubercles. There's lots of kinds of tuberculosis, but for some reason we named the entire disease off of the lung problem because most of them are pulmonary tuberculosis. So it's a nodule in the lung that undergoes necrosis in the center, and then it encapsulates if they're latent. If the person gets immune suppressed, worn down, stressed out, it manages to grow, spread the infection, make more, and spread to other places. So a tubercle is that lesion in the lung cavity that is filled with a Mycobacterium tuberculosis bacteria. So it's a gram-positive bacteria. 2 billion people in the world with TB. What's the total world population? A little over 6, almost 7 billion. That's like a little less than a third of the population worldwide has at least latent TB or active TB. That's pretty wild, huh? There's tons of it out there. America is not one of the frontline places where we're loaded with it, but we do have our fair share. It's out there. So at least one person every second in the world is getting infected with TB. So the World Health Organization, it's one of their big things. Okay, each year, 9 people around the world will get sick with TB, 1.5 million deaths, takes one life every 21 seconds around the world. Huge, isn't it? That's huge. Okay, and those who are HIV positive patients that get to end stages and we actually converted to AIDS, tuberculosis is one of the subsequent infections that they can get, and it's one that's really highly fatal for them. So there's just a couple of the infections that actually kill them. TB is one of them. So you'll be doing more. You won't be doing more on TB, but you'll be doing more on HIV next semester. So, but one of the problems we're having with TB is the drug resistance. So some TBs are becoming drug resistant, where they aren't able to be treated with the frontline drugs. They take additional drugs to be effective. It's pretty crazy, sad. Okay, so what makes somebody at risk for TB? Old and young, the very young and the very old. It's an infection. The very young and the very old. Socioeconomic status. It doesn't matter how wealthy you are, you can get it. But the impoverished and people living in crowded living conditions are more likely to contract it because of the proximity of living conditions where people are breathing closely on other people. It's not like if I'm here and you're there that I'm going to give you TB, but close proximity breathing can do it. People breathing, coughing, sing. I love the health department says singing close to your face, because it's spread. Is it which route is it spread through? Airborne. It's one of our airborne illnesses. Measles could be airborne. This is airborne. Airborne, which means the book talks about airborne droplets, but it doesn't mean it's a droplet infection. It's these little micro things that like aerosolizes in the air, and they can hang suspended in the air for several hours after the person walks away from that site. So it's an airborne disease spread. So one of the other things is people who don't know how to prevent infection are more likely to get an infection, and TB is one of those. Other comorbidities, diabetics, people who have immune suppression and on immune suppressive drugs, right? All those things can do it. Crowded living conditions, jails, orphanages, homeless shelters, places like that where people are packed in there in large amounts, breathing the same air over and over. And then lifestyle behaviors, because there are many behaviors we can engage in that make us more at risk for the spread of bacteria through airborne. Because they immune suppress us, so drug and alcohol use certainly, frequent sexual contact with people, especially if you don't know if they have TB or not, could do that. So lifestyle behaviors can affect this. All right, so anybody with altered immune function. So anybody on a MAB, FAB, some of those, right? We know the SEPs. It's disproportionate in the poor, the medically underserved, the homeless, those living and working in institutions. Guess what? That could be us. because we work in healthcare institutions where people have TB. So we can get more at risk for that. But long-term care facilities, the elderly, TB can spread rampantly through a facility like that. Prisons, shelters, hospitals. So Asian people are the most commonly afflicted ethnic group. So those in Southeast Asia, the Far East, that's where the TB is at the highest proportion. It's followed by Pacific Islanders, American Samoans, things like that. And then if of the people in the U.S. with TB, 60% of those were born outside the U.S. So the tuberculosis bacillus, we breathe it. It enters the airway, lands in the little alveoli, sets up housekeeping, and it encapsulates, basically. It sets up a circle that contains the bacillus in the center, the mycobacterium in there, because this little necrotic mass that it makes. And it's filled with purulent and infectious stuff. And then if that tubercle ruptures at a time of immune suppression, stress, overwork, sleep deprivation, whatever, then it spreads, it makes another one, and then more of them. Right? It's not just like one, it makes several at a time. All right, so the antecedent, you know all this stuff about antecedents, attributes, blah, blah, blah. We have to do that over and over and over and over and over again. In my mind, antecedents are the things we have to assess for. Because if you have a healthy immune system, you're less likely to get TB. So a non-specific defense, or your non-specific defenses like airway mucosal have to be intact. Well, you're less likely to get it then, right? So we're assessing that. I think of antecedents as assessment, always. An innate immune system, functional lymphatics, blah, blah, blah. Easy stuff. So the problem with TB is that you'll get exposed to it, and you will get one of two types of infections, right? And you talked about those. What are those two types of infections? Active or latent. Active or latent. Okay? It can affect any body system. It's really most common lungs, but kidneys, spinal cord, bone. There's TB of almost every major organ function. Central nervous system TB is highly fatal. But the pulmonary TB is the most common, the one we primarily test over, and the one we most often see.
Is that just because that's where it lands?
It's most route of transmission, and then it has to spread into the other areas to get there. And it's not. What if you had central nervous system TB? Sleeping next to somebody, walking around with them, dancing, singing, coughing on them is not going to give them central nervous system TB. So those kinds are not considered highly contagious. So I guess if you shared cerebrospinal fluid with them, you might get it, but that's a little harder to do.
What kind of routes?
The only one we ever talk about, pulmonary, because how often do you share cerebrospinal fluid with somebody? Really and truly?
Hopefully never.
Really? Okay, so latent and active TB disease, okay? Both of them are infections with Mycobacterium tuberculosis, you know that. Latent, you don't have symptoms of the disease. You got exposed, it sets up the little tubercles, you developed the antibodies. So it shows up on a TB skin test or a quantiferon gold test, shows up in some form or fashion, right, that you have been exposed. You have the antigen in your body, you have developed antibodies to it. So we know you've been exposed to it, but it's sitting dormant and not active, and so we can treat it with antibiotics and make it so it won't go active and spread. We're going to kill it here and stop it here. Does that mean your skin test will now convert back to normal? No, because the skin test is simply measuring if you were exposed to it, if you have the antibodies. You will still have the antibodies even if I kill the bacteria. So, but a latent TB infection is when you've been exposed but you don't have any active symptoms. You're positive for the skin test, you have no active symptoms, your chest x-ray is normal. If it got you to cough up a huge wad of sputum, we tested it, would be negative for acid-fast bacteria. On a sensitivity and culture report, it would show no mycobacterium tuberculosis growing, and you are not contagious to anybody else. There's lots of people walking around like that.
Question.
Yes?
Is this similar to the people who get immunized with it or whatever?
If you're immunized with it, we intentionally gave you it, but we didn't give it to you in your lungs. We gave you just the antigen enough that you would create the antibodies. You'll test positive, but we don't consider you as having positive latent TB.
So how do they differentiate?
history,
Yeah.
mostly. Because if I knew you had a Bacillus calmette-guerin, I can't say it right, immunization, then we know that's how you got that.
Yeah, because I had it, and every time my test was positive.
You're always going to be positive. You should have a chest X-ray. You shouldn't even be having skin tests anymore.
I have it every time. Just explain.
You should. That's what you should have. That's just to make sure you don't get pulmonary tuberculosis, but it doesn't mean you've ever been exposed to it. I have a positive TB skin test. You can think I have everything in the semester. I pretty much do. So I converted after I worked in ICU. You guys know that. It was one Christmas Eve. We had a patient come in with an unknown respiratory condition, and I was like alone in the unit. Christmas Eve. There's no other patients, so it was me and a tech were in there just hanging out. I was like, I'm going to give that patient the best care he's ever had. I mean, he got bathed, he got shaved, he got oral care, he got everything he could possibly wanted.
Merry Christmas.
And I converted. Whatever. He ended up with TB. Somebody finally went, maybe we should check him for mycobacterium, and we did, and sure enough, he's positive. That's okay. I took my prophylactic medications. My TB is dead, but I would test positive for TB. I don't do that test anymore because now that I know I have the tuberculosis bacillus in my body, I don't want to keep giving myself more of the antigen, right? Oh, here, let's give you a little more, a little more, a little more. It's like, no. I killed that off. Let's keep it negative, but I still will test positive forever and ever. But you do the prophylactic treatment and kill it off. But you were considered to have a latent TB infection. A TB disease is you're infected with Mycobacterium tuberculosis, but you have symptoms. Your sputum is positive, your skin is positive, your chest X-ray could be normal, but it might be abnormal, and you can transmit it to others. Those are the ones that we don't want walking around breathing and singing on people, lest you sing on people often. Okay, so we first would do a comprehensive history. Tell me about your symptoms. I'm speaking again. What symptoms would TB have? Coughing, fever, anorexia, fatigue. What is an infection? You feel crummy. And you've got a pulmonary infection. So you have symptoms like that. Okay? Known exposure to somebody with TB. Oh, my mother had it. My sister had it. My husband had it. My brother-in-law had it. I was in an area that's rampant with it. Those kinds of things in your history. If you were previously diagnosed with latent TB and now you have symptoms, it's possible for your latent TB to become active. Because a lot of people have latent TB, no symptoms or not, but they didn't take prophylactic medication or they didn't take a full course or they didn't follow the protocol. And later on, at a time of stress or other problems, their TB becomes active. And now they have the disease that's not latent, it's full-on active TB. So previous treatment for TB puts you at high risk, and we assess for it. Did you complete the treatment? Were you fully compliant with the treatment? Those make huge differences in your life. One of the biggest reasons TB is spreading and becoming antibiotic resistant is people are not compliant with the medication regime. You probably saw it on the CDC website. I think I had you in there quite a bit for your LA. Okay. So any underlying condition that alters your immune function puts you at risk, and we want to make sure, like diabetes or any other illness that makes you immune suppressed. Okay, so pulmonary TB in an adult, a cough with or without sputum, hemoptysis, what's that mean? Coughing up blood in your sputum. Chest pain, it hurts to have a pulmonary infection. A loss of appetite with weight loss, that's very classic with TB. Night sweats. There's lots of pulmonary infections that give you night sweats. I don't have any idea. You've run the cycle of fever, and when the fever breaks, that's when you sweat. But it happens with pneumocystis jirovecii and AIDS. It happens with pulmonary TB. It also happens with lymphomas, night sweats. That's cancer lymphatic symptom. It's very common with those, like Hodgkin's and things like that. But night sweats. If a patient says, oh, I have fever, chills, I'm coughing, I have night sweats, you're like, oh, you've got some pulmonary infection. Put on my mask and I'm taking care of things.
So the night sweats has to be like every night?
No, it doesn't be every night, but it's calm. They'll have common night sweats.
How much sweat is
Because sometimes you wake up sweating.
Oh, yeah. Our mattresses, our blankets, all those things can make us hot at night,
Okay.
yes. But it's a cycle of fever. They have their fever breaks at night, and they'll have diaphoresis at night. Just everybody's, if you're sweating at night, you always sweat at night, but you're not coughing, you haven't been exposed to TB, I wouldn't get too worried about that. I get a different mattress pad and a lighter blanket, maybe turn up your hair, I don't know.
You kind of feel like you peed yourself.
Okay, that's menopause. That's a whole different thing.
Touche.
So extrapulmonary, it depends on what's infected. If it's your kidneys, you get blood in your urine. If it's your cerebrospinal fluid in your back pain, headaches and confusion in your meningeal layers, larynx, you can have laryngeal TB where it's not in your airway, in your alveoli, but it's in your larynx, then it would cause hoarseness of your voice. All right, so what do? First thing, either the blood test for the IGRA, interferon gamma release absorptiometry assay. Quantiferon gold is the one they mostly do around here. There's also a T-spot test. Either of those are acceptable. If you've been exposed, it will be elevated, positive reading. A TB skin test is also very common. That's the PPD, or the Mantoux skin test, where we take an intradermal needle and inject it under the arm 0.1 of tuberculosis venom. It's not venom, but whatever. It looks like a snake, but it's kind of venomous. It's hurt you. Of the TB bacteria bacillus under your arm. Wait for a couple days, 48 to 72 hours, and see if you're positive. What constitutes a positive reaction? You have to look that up in your life.
5 centimeters of heart.
It's of what? Induration, elevation. And it has to be 15 centimeters for a person that's not a healthcare worker, not immune suppressed, no previous history, no risk factors, right? 15 millimeters. 10 for us healthcare workers. If I had HIV or cancer, 5. Why is their inflammation less than my inflammation?
Immune response.
Because they're immune suppressed. So if I give you an antigen, you don't react as much to it. Most people, a lot of students come into my class thinking, oh my gosh, if the patient has HIV, they're going to have a huge reaction to TB. That's not the case. They don't have an immune response. So they go, oh, you've exposed me to something. So what? Right? Because they can't fight it. It doesn't know how to fight it. So, and then once we've determined that this is positive or this is positive, we're going to follow that up. The doctor's going to do a chest X-ray looking for tubercles, may or may not be positive. We're going to get a specimen of your whatever fluid we think it is, which would be urine, cerebrospinal, but most often sputum. Check it for Mycobacterium tuberculosis, right? And then we're going to do biopsies if we have to, whatever we need to confirm the diagnosis. So we just did this. Can you do the Mantoux test the day after exposure?
No.
You got to build antibodies before it can be positive, so they'll always make you come back in a couple months later. All right, we talked about what's positive, and this was straight off the website, and it's in here, and we just talked about it, about whether you're immune suppressed, you're high risk, or you're habit, whatever. So, if you are high risk, you should have sputum specimens, acid fast bacillus, and a smear of the culture. If you have pulmonary TB, that's how we determine if you're infectious or not. If you have a bacterial and enriched culture that is present in your sputum, we're like, you are so definitely susceptible, so definitely contagious. And then we have to know that that's negative before we say you can go back out to your job where you're exposing people to your breath before you can go back out into that world. So if you're a healthcare worker, you test positive, oh yeah, I got active TB, I can take my culture specimens, come back positive. Your lungs may not be really bad yet, but your sputum may have stuff in it. And so we test positive, I'm contagious. Do I get to go to work? But I take my medicine, and after a couple weeks of my medicine, I can check it again. And if I'm negative on 3 consecutive smears, right? 3 different specimens on different days at different times, then they say, okay, you're no longer contagious. Do you still have to take antibiotics? You have to continue your treatment for months and months and months and months, right? TB treatment is not 2 weeks or 1 week, 10 days. All right. Just because you have a negative smear, it does not rule out that you have TB disease. Isn't that weird? The culture is what we're looking for, not just the smear.
So,
Different lab test.
with starting medication, at what point during that process would you start medication?
I was the day after I found out I have a positive TB skin test. I'm going to
So the positive
health
skin
department
test,
or positive skin test or
Or
quantiferin
blood.
gold. They're going to send me to the health department or whoever the
and you
person
culture,
is at your area.
even though you're taking medication?
They probably, they got to find out if I'm active or not. My healthcare provider will ask me some questions and refer me for treatment. How often, when do I start my treatment? ASAP.
Okay.
Because the earlier we can start treatment, the less people I'm going to infect. So. All right. The chest x-ray may show damage to the lungs, but alone it's not diagnostic. People who work in healthcare are exposed to a lot of crud, right? We get exposed to stuff, and our immune system goes crazy, and we breathe it in all the time. And most healthcare workers have granulomas in their lung, and they're not all TB. They're just scar tissue from previous exposures to infection. And so they'll have little spots all over their lungs from exposure to stuff, but it isn't all TB. So you may and or may not have an abnormal chest x-ray. That's the point. Some of us have weird chest x-rays, but it's not TB. Just because we work in a high-risk area that we breathe in a lot of junk. All right, so latent disease treatment. INH,
How do you say the name of that?
isoniazid.
Isoniazid.
Isoniazid. That is INH. That's much easier. That is that and rifampin. Pretty much rifapentine's okay. We used it, but INH, rifampin are combination drugs thereof. These are the drugs we use. Okay. This is really important. You understand INH and rifampin, and you saw those drugs on some learning activity somewhere. What you need to know is they take it for a couple months, and that's their initial treatment, once a week for 3 months, 12 doses, daily for 4 months, 120 doses, depends on which treatment regime your healthcare provider chooses to do. Now, what increases the success of these treatments? Compliance. So what do they call that when the person has to come in and we watch them take it?
Direct observation therapy.
DOT, direct observation therapy. So we have them come into the clinic, we hand them their drug and watch them swallow it, and we know they took it. Directly observed therapy, the direct observation therapy. That's a big deal. Compliance here is huge in managing the control and the outbreak of TB in our society. Can everybody do INH? Does that drug work for everybody? It affects the liver, it affects peripheral nerves. Not everybody is able to take that. So again, it just depends on what. But the longer your treatment, the more doses of something you have, the more compliance becomes a problem. So that's why that 3 months of INH is ideal if somebody, INH and rifampin, or RPT. If they can take that, then that's even better, right? Then even better. When I got my positive test, I had to take INH for a year, but it was a long time ago. And the CDC just updated these treatments for latent and active TB. When was it? It was like in September or August of last year, end of the summer last year. I think Professor Matranga said that's why all the sites haven't updated their stuff yet. It's only been out a little while, so everybody's still reacting to it, and sometimes they're still using old treatment modalities. But it's okay to do it for a year. You're not going to hurt the patient. It's just less likely to be compliant, right? All right. So if you have active TB, it has to be multiple drugs. There's 4 drugs that are first-line drugs for active TB. They include the ones that were used for latent TB. But latent TB they're not contagious. It's not active. And so we can reduce those dosages and just kill it where it is before it gets bad. Active TB means we need 4 drugs, 3 or 4 drugs, longer term. We have to wipe this out because they are contagious. And so it's 6 to 9 months of therapy, and there's my 4 drugs: isoniazid, rifampin, ethambutol, and pyrazanamide. If we need to, we can add second-line drugs if they have a resistant strain, because there are a couple other antibiotics on our list we can give. So here's the CDC recommendations. I took those. Somebody said, can you change it on the canvas? Because I just had it at one point cut and pasted in to the page. It's in the PowerPoint, so if you're interested in seeing it, it's in the PowerPoint. What drugs do you need to know for this test? That's what the next thing you're going to ask me, right? You need to know the names of the big four. Recognize them, they're used for TB. You need to know the stuff you have to teach and know about INH and rifampin. That's why they are in the learning activity, because those get more attention from me. They're more common, more commonly used, more commonly, you're more likely to see it. I want to be sure you know those two. Okay? All right, so drug resistance. Multi-drug resistance is a TB strain that's resistant to our big two, INH and rifampin. And if the disease is resistant to those two, we say they have multi-drug resistant TB. That's a problem. Extensively drug-resistant TB is an even bigger problem. They're resistant to isoniazid, rifampin, and fluoroquinolone, and any other 3 injectable second-line drugs. This means very little we have is knocking this out. This is where TB has become a worldwide health problem, because we have so many strains of multi-drug resistant TB. And it's becoming, in the immune-suppressed population, people that are non-compliant with their treatment is where that's growing so much. And it's becoming that's one reason it's a world health problem. We were doing really good with TB in the 80s, 70s and 80s. We were really, it was going down, 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 down. Even worldwide, our trends were kind of declining. And then, boom, HIV hit and became an epidemic worldwide, and TB rates dramatically climbed again. All right, so we start at the sign of a positive TB skin test or positive chest X-ray and the development of symptoms. You're infectious for a couple of weeks after your treatment begins. Then we can start checking those sputum cultures to see if you're coughing up stuff still. Does that, and again, we say, no, you can't stop your drug just because your sputums are negative. Is that a risk?
Yes.
Somebody's going to go, well, I'm not contagious anymore. I'll stop taking my stuff. And then now, only the survivors were the ones that weren't killed by the smallest doses. The survivors are the bigger and stronger ones, so the big bad stuff grows. So during this time, when you are actively having TB, you should avoid public transportation, Walmart, the Super Bowl arena, places there's tons of people, right? And going into hospitals and nursing homes and orphanages to take care of people. You should stay away from that, right? We aren't going to put everybody in the hospital. Just because I have TB, do I have to go to the hospital? No, if I'm not critically ill or significantly ill, I can stay home. The problem is, I have to be sure I follow my treatment regime. We see people in the hospital with TB if they have comorbidities. I mean, it's really possible for somebody to come in with heart surgery because they had a heart attack. And lo and behold, they may be positive for TB, or they had been exposed to TB and never knew it. And so we found it when we started doing chest X-rays and things, right? So we only hospitalize somebody when they have significant disease, disability, or comorbidities. So again, who's infectious? You meet 3 criteria to be non-infectious. Your 3 consecutive negative sputums, clinical improvement of your symptoms, and compliance with your treatment regime for 2 weeks. Those 3 things happen, you can go back to work. So drug resistance, this was all over the CDC website. It's the leading cause of ongoing transmission of TB. Somebody starts the meds, they don't finish it. So a specific treatment plan is necessary. Usually it's your health department in whatever community you're in that monitors and keeps up with this. TB is a reportable illness. So when somebody's positive for TB, either latent or active, they have to be reported to the health department. Health department will make contact. They'll also reach out to people that are likely to have been exposed by that person, right? Make sure they get tested. They will manage the testing. It's just like a venereal disease, only doesn't have quite the stigma, right? But it is reportable, and you'll come in for therapy, and they will watch you take your drugs.
So how do they report that someone in the area has TB and alert proper people if they were exposed to it without violating HIPAA?
They just have to call them and say, HIPAA rules for the sake of public safety. The health department and the CDC they're bending to extent. They're not going to say, oh, Allison has TB and she exposed you. They're going to say, we have direct confirmation that you've been exposed to a patient with tuberculosis. They'll even send schools, like a kindergarten kid will come back positive for TB. They'll send an email to the whole kindergarten class saying, somebody in this child's world has tested positive for TB, take your kid in to be tested. They say somebody. They won't say Susie Q sits next to them in science class.
Is it typically infection control that reports it, not?
Infection control will generally report it. Your hospital will have a protocol for reporting things, whether it's child abuse, elder abuse, sex abuse, rape, things like that, or infectious illness. There's a protocol at every hospital for who reports, how it's reported. The most recent edition of the Board of Nursing newsletter, once you're licensed, you're going to get a quarterly publication from the Board of Nursing filled with all kinds of cool stuff that tell us what we have to do to keep our licensure up and what the latest laws are and everything. And they had a really great article on reporting things and how do you report stuff. And what they were dealing with a lot of was how do you report a peer who you think is substance abusing, or how do you report things that are like child abuse and things like that, harder to report stuff. So I'll bring that article. It's pretty good. All right, let's see. Secondary prevention. Primary prevention is stay healthy, don't get exposed, right? Wear your airborne masks if you're taking care of a patient. So, secondary prevention, screening everybody who's around that person. Okay, yes, screening is primary too, I know. But secondary if we already know that. Implementation of it's actually not primary. Screening is not preventing, ever, ever, ever. I guess you knew that. Implementation of respiratory precautions. So that's your airborne isolation and compliance of effectiveness of your meds. There's your big three we do. Nutrition, physical therapy, respiratory therapy, pulmonary rehab, breathing treatments, all secondary, going to help them. The drugs we're on all have toxic effects, right? We talked about INH and rifampin, but the others also. They cause ototoxicity, hepatotoxicity, they can cause visual changes. So we might have to have other health specialists come in to deal with the side effects of these medications and deal with that. That was also in your case study, I believe. Let's see. We did first line, we did second line. Oxygen if they need it. A chest tube insertion. A chest tube. What is that? Have you had patients with those? Some of you have. Depends on the floor you were on, level 2, right? A chest tube is a tube that sits in your pleural space. Your lung expands, and we breathe air in. Okay? But the space outside your lung, between the lung and the chest wall, is negative. It's negative pressure space, right? So our chest expands, and that makes our lungs expand. If anything breaks that negative pressure by having like a lung pop, like a lesion in the lung that ruptures, or an ice pick stuck to your chest, letting air in. I love ice picks.
If I ever see an ice pick, I'm walking away from you.
Then that would break the negative pressure seal, right? Because now you have open air coming in. I don't use ice picks. So the ice pick in the chest, or the person with TB who has open lesions in the lungs and they're coughing really hard and they cough a bleb open and it ruptures their lung, and then that lung now, the negative pressure's messed up, so the air leaves the lung, fills up that space and compresses on the lung, causing the lung to collapse. So we'll put in a tube in the pleural space, put it as a negative pressure system so it has a slight vacuum on it, and it will help re-expand the lung. So chest tubes are used if the patient has a rupture of any of the lung tissue because of the tubercles. Great word. Or if the patient has significant respiratory changes, like destruction of pulmonary tissue from those tubercles, we can actually take out a lobe or a piece of the lung, or even a side of the lung if we have to. A whole side. Now, we talked about these drugs, and if they're resistant, then we can add some of the others. And look, 2 to 2.5 years if you have a drug-resistant type of TB. Risk of non-compliance, huge. The family has to know, the patient has to know, the health department has to be involved. Everybody has to help maintain compliance. Oh, that was easy.
I have a question about the medication for this.